Yes, ma'am.
Okay. So I've titled it as Vaccine Technologies Aimed at Protecting Communities and Saving Lives. So there is a public health angle to it, as well as, personalized vaccine delivery approaches based on need. So we all know that vaccines have had a huge impact. I do believe even anti-vaxxers can't deny the fact that vaccines have prevented at least 2 to 3 million deaths from different microbes every year. And this happens even in low and middle income countries where disparities in vaccine deliveries are huge. It reduces treatment costs because you're preventing infection. It prevents the overwhelming of the healthcare system. And by delivering vaccines in the right manner, in the right schedule, and on a larger scale, it increases herd immunity, limiting transmission of the microbe, and it also reduces the severity of illness. So, in the case of, say, influenza and other respiratory infections, you after a influenza vaccine, you may actually pick up a flu, but it is much milder. We have also seen that with COVID-19. We do pick up a very mild version of COVID even after those who have had 5 and 6 doses of mRNA vaccines, as we have heard of in the West, they still pick up COVID, but it's a much milder version. The vaccination timeline is very checkered. This particular picture doesn't depict every vaccine that was developed, but just shows some of the important landmarks. And starting from the 18th century, the father of vaccinology, Dr. Edward Jenner, which was a form of a live attenuated vaccine, followed by Louis Pasteur the following century, where he gave a classical inactivated vaccine, then the first tetanus vaccine in 1890, the tuberculosis vaccine in 1921, the pertussis vaccine 1926, and so on. You can see that the timeline is very checkered through the starting with the 18th century, the 19th century, the 20th century, where we know we are very familiar with these vaccines, the MMR vaccines, some countries even being rendered polio free, the world being rendered smallpox free, then creation of other vaccines like the chickenpox vaccine in the early 80s, the first nasal vaccine for influenza in the beginning of the century. Then in 2006, we had the introduction of a novel vaccine, virus-like particle-based vaccines for HPV. We also had the malaria vaccine being created later the century. And then, of course, 2020 and thereon, we know the slew of COVID-19 vaccines that came into being. So it's a multifaceted landscape with live attenuated, whole inactivated, split inactivated, recombinant viral vectored vaccines, which are far more in use than bacterial vectored vaccines, then virus-like particles, which I referred to, nucleic acid-based vaccines, which may be DNA or RNA, recombinant protein. The first recombinant protein vaccine really was the hepatitis B vaccine, 1986. Then synthetic peptide vaccines that has not really taken off very well for human use yet. And then for purposes of completion, another immunogen in the form of toxoids. So I will take you through the different genres of vaccine, highlighting some of the good points, the merits, and some of the demerits. So live attenuated vaccines, as we know, is really a vaccine that contains a weakened pathogen that has still the capacity to replicate in a vaccinated individual. So it continues replicating, and we have any number of examples. The Sabin vaccine, which is the OPV, the measles MR vaccine, earlier introduced as the MMR, now the MR vaccine. Then we have varicella, we have the yellow fever vaccine, the BCG, bacterial vaccine, the live attenuated bacterial vaccine, rotavirus vaccines, and the nasal influenza vaccine, also the nasal COVID vaccine that Bharat Biotech had come out with, which I will speak about later. Advantages of live attenuated vaccines, as we know, it gives a very comprehensive immune response because the virus is replicating in the vaccinated individual, does not require adjuvants, usually delivered in the natural portal of entry. And many of these vaccines, you just need to give one dose. Of course, there are exceptions. It's not a strict rule. And one of the disadvantages is that administering protracted replication in immunosuppressed can lead to administering live attenuated vaccines in the immunosuppressed can lead to protracted replication. Typical example being that of OPV. When OPV is given to people who are immunosuppressed, particularly those, say, with severe combined immunodeficiency or any of the primary immunodeficiency disorders, OPV continues to replicate in the gut of that person, and they become a source of spread of the vaccine-derived polio virus into the community. Such people ideally should not even receive an OPV, but children usually get diagnosed as having a primary immunodeficiency disorder few months into their after their birth. By then they've already got the OPV. So this is a risk with live attenuated vaccines. There's a risk of reversion to virulence, and also it requires a special infrastructure to manufacture. There are different types of live attenuated vaccines. Those that have something known as codon de-optimization, where actually you change the sequence of the codon to reflect the same protein, but it results in actually lower protein expression. And this is the same thing what you're seeing here, the natural virus, the protein sequence. And when you artificially do a codon de-optimization, the sequence may be the same, but because ultimate protein sequence may be the same, but because you have played around a little with the sequence of that triplet codon, it leads to an attenuated form of the virus. There's lower protein expression and so on. You could also introduce CPGs and UPAs, which really lead to more poor replication, poor expression, less infectivity of that particular vaccine strain that is found in the attenuated vaccine. And an example of another live attenuated vaccine is the novel OPV2. Now, we do know, I also told you that when we give OPV, another risk of giving a Sabin vaccine is that there's a theoretical chance that an attenuated version of the polio vaccine could actually revert and become the wild or virulent form, which could lead to a greater amount of spread of the wild virus and outbreaks of polio. So the novel OPV actually involves the creation of mutations or changes in the 5' UTR region, in the non-structural region here. They're actually in total 5 changes that happen in the 5' untranslated region and in the non-structural region, which results in the virus, this vaccine, the strain becomes truly attenuated and incapable of undergoing reversion. This is being used increasingly by many countries where they're trying to boost up the immune response to a poliovirus strain 2, not because it circulates now, but because antibodies are declining in different populations, and therefore to keep a population protected, you give this form of a live attenuated vaccine, which is very safe. We also know about dengue vaccine constructs. There are at least 3 candidate live attenuated vaccines. Dengvaxia made by Sanofi, the Takeda vaccine, and the vaccine made by NIH. The vaccine has different amount of expression of the four dengue serotypes, but they have undergone attenuation by introducing mutations as denoted by the yellow stars in different regions of the virus genome. You can see wherever the stars, those are the regions where attenuating mutations have been introduced. And or in the case of the Sanofi or the Dengvaxia, there's also been a 30 nucleotide deletion in the 3' UTR, which you also see here. Additionally, NIH, it's again mutations in the 3' UTR region. We now move to inactivated vaccine, very old technology. It has been used, time tested. It basically involves the killing of the virus using formaldehyde, using beta-propionolactone, and few other new chemicals that literally pickle the virus or the agent in question. And what happens is you have an inactivated vaccine that targets your immune system, and basically it produces a very, very good antibody response. The strength of the antibody response may sometimes be weaker than that of a natural infection or following a live attenuated vaccine. But the trump card for inactivated vaccines is they are very, very safe and can be safely even given to a pregnant woman if it so is warranted. But the problem with inactivated vaccine is because the immune response is somewhat suboptimal compared to a natural infection and live attenuated, you almost invariably have to give multiple doses. So here is Covaxin, our own indigenous COVID vaccine made in India in partnership with BBIL. ICMR made it. So this was a vaccine that used the original Wuhan strain, where they used the classic Algel, which is an aluminum hydroxide-based or alum-based adjuvant. And they also used a new adjuvant known as imidazoquinoline, which has a very good TLR. TLR is toll-like receptor 7 and 8 agonistic action, which increases the Th2 response. So you get a comprehensive Th1 and Th2 response. And it was intentionally formulated like that because in those days, in early days of COVID, we were very worried about reactions such as antibody-dependent cellular cytotoxicity, and therefore we wanted to bring up the element of boosting the Th1 immune response, and that's why this IMDG was introduced in Covaxin. We also have split inactivated vaccines where the virus may be disrupted with the use of detergents. The trivalent inactivated split virion influenza vaccine is a classic example. And the split vaccine actually rapidly activates multiple immune signaling pathways with cytokine production from the immune cells and therefore can invoke a quick immune response. We move to vectored vaccines. They deliver the genetic code of the antigen of interest via a vector. Genetic instructions for making more of that antigen of interest is stitched into the viral vector's genome. And common vectors, as you all know, are adenovirus, vaccinia virus, measles virus, vesicular stomatitis virus. And basically, you can see the genes that code for the antigen of interest is stitched into the genome of an vector or a carrier, so to say. Vectored vaccines may be non-replicating. Such vaccines are not able to make new virions. They can only produce the amount of genome coding for that antigen that comes with the number of vector particles that are there in the vaccine. But replicating vector vaccines produce new virions in the cell that they infect, and then these new cells can go on to make more and more of the antigen of interest. And we have n number of examples for the chimeric vaccine, JE vaccine. We know JE vaccine, you have both live attenuated and vectored vaccines, even inactivated vaccines. You have Dengvaxia, which is the example. Actually, it shouldn't be sitting here. It's more of a live attenuated kind of vaccine. Covishield is a classic example of a vectored vaccine. The Sputnik vaccine and all the 4 Ebola vaccines that were made in the last decade, end of the last decade, are all examples of vectored vaccines. It's a well-established technology, provokes a very good immune response of B and T cells, but there is one disadvantage. If the host has been exposed to that vector, if it's a form of an adenovirus or say a vaccinia virus, then the effectiveness of that vaccine comes down because there'll be an antibody response against that vector. And then in terms of manufacture, there's some amount of complexity. Bacterial vectors are not yet widely used, but basically it involves the enzyme digestion and introduction of a gene E in and making a recombinant plasmid, which is this comes from a phage, bacteriophage, and this is then once introduced into the bacterium, this gene E is able to actually make a funnel lysis-like structure within the bacterial envelope. So what happens when this bacterium that contains this plasmid is propagated in the laboratory, it makes bacteria that have this particular plasmid and expression of this E gene, which causes this funnel-like structure, which can help in lysis. And this leads to the breakage of the cell wall of the of the bacterium, leading to the production of so-called bacterial ghosts. So bacterial ghosts shed the contents of their cytoplasm and therefore can actually release the antigen of interest as well. This is not as widely used as virus vectored vaccines. Now, I refer to virus-like particle vaccines. They are made up of, they actually are made to code for mainly structural proteins. And importantly, the VLPs or virus-like particles are really empty shells. Head-on, they look like the actual virus, but there's no genetic material inside them. The target genes are incorporated into plasmids that are introduced into several expression systems that may vary from bacteria to yeast, to insect cells, to mammalian cells, and even plant cells. And finally, these target genes self-assemble in such a way that they form an empty shell that you see on your far right with no nucleic acid within it. So it looks like when you look at it spot on, end on, it looks like the virus itself. It has all the conformational proteins that can evoke a very good immune response. And the best known examples are the HPV vaccines, be it Cervarix, Gardasil, Gardasil 9, Secolin, which has the Chinese HPV vaccines, our own Indian vaccine, Cervavac, made by Serum Institute of India. These are all VLP-based vaccines. In fact, all the HPV vaccines thus far are based on this technology. We have some of the newer HPV vaccines also adopting VLP. People are thinking of making VLP-based influenza vaccines and also VLP-based COVID vaccines. The advantages are these VLP-based vaccines are highly immunogenic, eliciting very good humoral and cell-mediated immunity. You can make it both for enveloped and non-enveloped viruses, but the bioprocessing is is rather complex. Subunit vaccines are basically acellular vaccines containing a part of the whole organism. And we have typical examples of polysaccharide vaccines, say of pneumococci. But this We know polysaccharides are not, and even of meningococcal vaccines, are not very good immunogens. They are good for peace, provoking humoral immunity, not T cell immunity so much. But once they get conjugated to a protein carrier, then the immune system recognizes it much better, and the immune response is definitely improved, with B and T cell responses being induced. And we have examples of the pneumococcal conjugate vaccine and the HIB vaccines as well. Then we also know about protein-based vaccines such as the hepatitis B vaccine, the shingles vaccine, the acellular pertussis vaccine. This is a well-established technology suitable for those with compromised immunity. If it has to be given to pregnant women, may be given. It's relatively stable, very good if immune response, but these invariably require adjuvants and booster shots, or multiple, I would say not boosters always, but multiple doses of vaccines. Like for hepatitis B, we have 3 doses that is part of the primary vaccination. And earlier it was considered relatively complex to manufacture, but now there's quite a bit of ease of manufacture. The nucleic acid based vaccines, I'll touch upon the mRNA vaccines first. And we do know that the mRNA vaccines involve the introduction of mRNA into a carrier particle. And most often it is a nanoparticle where the mRNA, once introduced, goes on to make a protein. The mRNA from the vaccine does not ever enter the host cell nucleus and has no risk of altering the host cell's genome. There are 2 types of mRNA vaccines, self-amplifying and non-replicating mRNA vaccine. Self-amplifying are sometimes referred to as SAM, and the non-replicating is referred to as the NRM vaccines. Basically, self-replicating vaccines requires less amount of antigen mRNA for more of protein is generated when you use self-amplifying mRNA, because they also introduce the enzyme, the gene of the enzyme replicase, and therefore the amount of vaccine you give can be less with self-amplifying mRNA. And we again have n number of examples of mRNA vaccines. Indian vaccines being the Gemcovac, the earlier version of the Indian COVID vaccine, and then the Gemcovac for the Omicron strains. Zika vaccines also are following this route. And now we find a whole slew of microbes will be following this path. What are the advantages? It allows quick modification of the immunogenetic transgene whenever you are encountering quickly emerging variants or mutants of the virus, which we saw with COVID. So in companies such as Pfizer and Moderna could keep making the nth version of the mRNA vaccine because it's very nimble for change. It's also amenable to huge scale up, several billion doses in a year, provides good cellular immunity. There have been not mild safety events, but moderate safety events. We all know about the myocarditis and some of the cardiac complications. But if you look at the overall denominator, even those side effects are minuscule compared to the number of people who are vaccinated. And the other disadvantage is that it does not lend itself to easy storage and stability. It requires super freezing temperatures, minus 80 for storage, which doesn't make it feasible for low and middle income countries. Now, many of these vaccine agents are carried in a lipid nanoparticle that may have different forms of lipid in it, which has the advantages of actually providing like for instance, the ionizable lipid, which enhances the electrostatic interactions, cholesterol, which decreases the permeability of the lipid nanoparticle and therefore enhances its stability, the helper lipid function, which again increases its stability and fusogenicity, and the polyethylene glycol lipid, which prevents non-specific protein absorption, particle aggregation, and controls or fixes the lipid nanoparticle size. And obviously, this has all these technologies have been used in using lipid nanoparticles to carry the mRNA in recent years. We have also nucleic acid-based vaccines of the second order, namely DNA vaccines. These are engineered DNA used to induce an immune response. So basically, when DNA is introduced into the muscle, it's taken up by the myocyte. It may be also taken up by the antigen-presenting cell. And then from there, it is presented directly to the CD8 cell or to the CD4 cell, which gives critical signals to the CD8 cells and the B cells to enhance the T and B cell immunity. It's preferably delivered using a needle-free approach. I will expand on that. And the first DNA vaccine and the only DNA vaccine used during COVID times was ZyCoV-D, made in India again. It's a thermostable, rapid design construction, better safety as compared to even live attenuated vaccines. But it has been seen that its immunogenicity is not so good. Technology is not available widely, and there in particularly among prospective recipients of the vaccine, there's always a fear that will this foreign DNA integrate to the host DNA. Now, this is usually administered by a special electroporation technique. It's called the pharma jet, where the cells and the plasmids are first mixed together. The plasmids contain the DNA of interest. They are mixed together, and using an electric impulse, this creates pores in the cells transiently. Plasmids enter the cells to the spores, and the pores seal after the plasmid gets into the transformed cell. And you can see how this actually goes through the different layers of skin. And DNA vaccines have to be delivered using this device. Synthetic peptide vaccines really are short synthetic sequences of amino acids, basically peptides, that code for portions of the pathogen, which we consider are most immunogenic and would trigger a good immune response. They need to be adjuvanted, and this adjuvant and peptide conjugate usually is introduced through targeted delivery, taken up by APCs, dendritic cells, and then presented to the immune system. Today, there is no licensed vaccine of synthetic peptides for human use yet, but vaccines under development may be extended not just for infectious agents such as HIV, influenza, HBV, and HCV, but mainly in the realm of cancer therapy. So we will see more developments in the field of cancer immunotherapy in the future using synthetic peptide vaccines. Toxoids, as you all know, basically serve to provide, innocent version of the toxin. So as graphically shown here, it contains all the important antigenic determinants, but lost its toxin moiety, and therefore is able to generate antibody response to this toxoid. And we have the classic examples of tetanus and diphtheria toxoid. What are the innovations to vaccine? Novel adjuvants. Then there are immunogens, novel immunogens, which we will be talking about. I'll also allude to novel vehicles of delivery, novel routes of delivery. And when we talk about vehicles of delivery, you know that using lipid-based or lipidic carriers have been very, very useful, be it solid lipid nanoparticle or a micelle or a microsphere or a liposome or a virosome or an emulsion or a immunostimulatory complex or the classical nanoparticle. How it helps is that these lipid-based vehicles help to enhance the antigenic delivery by preventing the antigen from getting easily degraded, and also facilitates the slow uptake of this antigen into the antigen presenting cells. It also you can have targeted delivery straight into the tissue and the cells in the tissue. There can be controlled release, so there's prolonged exposure to the immune system. These particles are biocompatible and biodegradable. And finally, they improve the immunogenicity, not just cellular, but also humoral immunity. These kind of lipid-based particles can package mRNA and DNA, can package proteins, can package synthetic peptides, and even subunit components of the virus. And this just shows the sequence of development of vaccines that have such. Now, I just want to spend a little time with adjuvants. We are all very familiar with the aluminum-based adjuvants. They have been used since time immemorial. Very good for the immune system, humoral immune response. So we call them adjuvants that comprise of mineral salts. Then we have MF59, which contains which is an oil in water emulsion, which has a compound known as squalene plus 2 surfactants. It is being used for some vaccines. You can see here, in addition to good humoral immunity, the Th1, Th2 response improves. Then we have the ASO3, it's squalene in water with alpha tocopherol or vitamin E. And sometimes it has polysorbate 80. And again, you can see here the humoral and cell-mediated response is actually getting better. We have ASO4, which has aluminum hydroxide, plus a TLR4 agonist. It gives a long and strong and long-lasting response. ASO4 has been used for even the H1 ASO3 was used even in when the H1N1 influenza vaccine was made. ASO4, the classic example being that of Cervarix and Fenrix, hepatitis B vaccine, and the hepatitis HPV vaccine. You can see that you get, in fact, the Cervarix did very well with this adjuvant, in fact, better than Gardasil. But the only problem is it depicted less number of HPV genotypes. ASO1 contains liposomes and the bark of a plant from South America called Quillaja saponins. It's like what you might call a surfactant-like effect, and it is a powerful, again, TLR4 ligand. You can see very good both humoral and cell-mediated immunity. You see that being used for Shingrix, for instance. Then we have the CpG 1018. It's a immunostimulatory sequence. Basically, it's an oligonucleotide which has a very good TLR agonistic activity, provides a strong and targeted immune response. Then you have matrix M, which is basically made up of again, the Quillaja saponins, and may have cholesterol and phospholipids included in it, and also gives a comprehensive immune response. You might have some different forms of lipid particles, which I alluded to, the use of different formulations of lipid. And then I also spoke about the IMDG, the imidazopinolene. This is its official name. It is a powerful toll-like receptor 7 and 8 agonist mixed with aluminum salts, and again gives a comprehensive immune response, as we saw with Covaxin. Now, what are the novel routes of delivery? It could be nasal, it could be intradermal. I'll give examples of it. Microneedle and pharmajet we've already spoken about, so I'll speak about these 3 types. Of course, oral, as I referred to the novel OPV2, those are novel vaccines given by the traditional route, the oral route. but I will stress on the nasal, intradermal, and microneedling. So when we come to nasal, you remember I said I'll speak about BBIL's nasal vaccine, the first nasal SARS-CoV-2 vaccine made in India. It simulates a very broad immune response, neutralizing IgG, mucosal IgA, and T cell responses. The immune response is at the site of infection in the anterior nares, essential for blocking the virus that gets in, and also good for preventing further transmission. It's feasible because we have organized immune systems in the form of the NOLT found in the nasal mucosa. The great thing is it's non-invasive, needle-free, comes to the natural route of infection, absolutely no injuries and needle-associated risks. And obviously, a great ease of wide-scale transmission, administration, and also, therefore, high compliance from the persons who are going to get vaccinated. So we also know about the flu mist for influenza. That also is introduced to the anterior nares, mimicking the natural route of entry of the pathogen. And these are examples of novel routes, and we will see more of them coming. There are already others, but there we'll see more coming into this category. Intradermal vaccination, you are all familiar with this. Inactivated polio vaccine. In our country, we actually give fractional IPV, and especially where we need dose-sparing formulations, even for rabies. We know that is part of the recommendation. In LMICs, you can give fractional rabies vaccine doses. Yellow fever vaccine is introduced intradermally, and the modified vaccine also is delivered to this route. It is safe, it's cost effective, and it's highly immunogenic. But what I did not mention here, and what we need to remember, is you need to have trained people to give an intradermal injection. While it is a very good stimulator of the innate immunity and eventually stimulates the adaptive immune system very effectively, to raise that pleb intradermally and deliver the vaccine well, slowly, and the full amount intradermally is a technique that many vaccinators need to train in. So therefore, may be more challenging to give large-scale intradermal vaccinations. Novel delivery methods, and I'm sure you'll have all heard of microarray patches. These are actually coin-sized patches which are covered on the inferior side with tiny needles coated with dry vaccine that can penetrate skin in a very painless manner. And the formula actually dissolves when the patch is pressed opposed to skin for a period of 2 to 5 minutes. It can be administered in a very accessible site like the wrist, and therefore lends itself to self-administration as shown in the picture, does not require cold temperatures for storage, weighs less than the needle syringe assemblage, does not require pre-mixing of the vaccine, can be administered obviously by untrained community health workers or even for self-administration. But upfront, there are higher costs of using large-scale microarray patches, but the coming years may see this getting less expensive. So there are many ways by which this microarray patches, they may have typically solid-coated polymers, which may be made up of polymer, or maybe in the very thin metal or silicon, and contains the antigen of interest, and is delivered into the epidermis and the upper dermis. You can see here. Sometimes these may be self-dissolving, where the formula dissolves into the epidermis and upper dermis. Sometimes it's hydrogel forming microarray patches. What happens is these antigen formula gets dissolved when the interstitial fluid is taken up. It expands, and the antigen is then delivered into this site. You can see the happening here. Or you might actually have hollow microarray patches wherein when this patch is pushed, the antigen goes out through this hollow tube-like structures into the upper dermis. So this is being tested in many low-income countries. Of course, it is by by agencies like Gavi and WHO, which are trying to see the feasibility of it. But this is a page you would like to watch out for. I just want to talk about vaccines that are challenging for that have been challenging for us, a big problem for the low and middle income region. I already referred to the dengue vaccines, and we also have two candidate malaria vaccines, the RTSS and the R21 with matrix M. They both target the circumsporoid and sporozoid antigen. Both require about 4 doses to achieve the complete immune response. Efficacy of this order in adults, higher efficacy in very young children. Both have met safety standards, and vaccinated people maintain good antibody levels, certainly for up to 2 years after the primary series. Both do not require sub-zero storage temperatures, which is very nice to know. And particularly the R21 matrix M has a long shelf life, comes in a single vial that does not need to be mixed, can withstand very high temperatures of up to 104 degrees Fahrenheit for up to 2 weeks, which makes it extremely portable across very resource-limited regions, which are also almost invariably malaria endemic. So this is good news for the world of malaria. And basically, both these vaccines ride on a backbone. These are the circumsporozoid antigens, which ride on a backbone of hepatitis B surface antigen. It's been a success story. Before I actually come to the universal vaccines, I wanted to actually touch upon these the TB vaccination. We know that has been a challenge for us, wherein BCG has not been able to do all that we hoped it did. So the stages of TB vaccine administration with a view to stopping and controlling TB may involve the use of prophylactic vaccines such as BCG and the another live attenuated MTB vaccine. There are many candidate TB vaccines of different genres. You might couple it later with the therapeutic vaccine known as the RUTI. It is a heat inactivated vaccine which is presented via liposomes. It contains specific antigens. Then you may, if in event of relapse or reactivation, you might use the therapeutic vaccine along with the MIP. The MIP or Immunovac is again heat inactivated Mycobacterium indicus pranae strain, which you might augment the immune response with. And finally, you might even use vectored vaccines such as the MVA85A and the ERAS 402, which may be used to augment or serve as booster vaccines with a view to reducing the burden of TB. I'll go back to where universal vaccines. Now, both the US Department of Health and Human Services, as well as the National Institute of Health, have been thinking of next generation universal vaccine platforms where you want to have a broad spectrum vaccine for the most likely big bugs that could cause major outbreaks and pandemics. They have coined it the word generation gold standard, where basically in the arena of influenza viruses, they have attempted to use multiple strains of pandemic-prone influenza viruses, such as H5N1 avian influenza strains, and but they have unusually used a old-fashioned technology, PPL inactivated whole virus platform. Clinical trials are due to commence in 2026. Universal vaccines are broad-based vaccines where you don't know where you're going to get the hit. So you want to make a pickle of the most likely candidates that could be the next major cause of an epidemic or pandemic. Pan beta coronaviruses, subunit vaccines also have been thought of, especially after we limped away from the last pandemic. So they have thought of making a formulation involving the different strains of Omicron, of SARS-CoV-2, SARS-CoV-1, the earlier SARS that hit us in late 2002, 2003, and the MERS coronavirus. And this platform may even lend itself to other big pathogens such as the RSV, the metapneumovirus, and the parainfluenza type 3. So this is again a concept that I'd like to leave with you. The principle of therapeutic vaccines, another genre of vaccines, and which we will see this genre of vaccines are going to expand. What is the mantra behind therapeutic vaccines? They express not only endogenous but exogenous antigens. They induce cell-mediated immunity, provoking cytotoxic T cells as well as CD4 cells, which will help in increasing the humoral immunity. And the ultimate aim of the therapeutic vaccine is to reshape the host's current immune response to finally trying and eradicating that microbe from the host and leaving it with a long-lasting immunity against that pathogen. So the therapeutic vaccines are primarily directed against agents that cause chronic infection. So we can think of therapeutic vaccines maybe in the future for TB and leprosy as well, and many of the chronic parasitic infections. When COVID started causing protracted illness like the long COVID, people thought they would make it even for COVID-19. But therapeutic vaccines also have a huge role in the arena of non-communicable diseases, particularly cancers, and people are talking of its use in Alzheimer's, dyslipidemias, so on. Therapeutic vaccines may be of different genres again. They may use neoantigens or proteins as well as nucleic acids to directly activate the immune system. It might come as a peptide or protein vaccine. It might come as a DNA or mRNA vaccine. It may be incorporated along with vectored vaccines. I'll give you an example shortly. It may be in virus vector vaccines or bacterial vectors. This is not yet very popular, or maybe even delivered in the form of yeast-based vaccines. And finally, therapeutic vaccines may be used using cells. So dendritic cells or genetically modified cells that are grown in cell culture, or dendritic cells themselves, which you know are very good antigen-presenting cells, may be the channels by which therapeutic vaccine approach may be taken. And there are many candidate therapeutic vaccines, but right now none have been really licensed for use. One is I'll give you the example of one that is undergoing active multi-center clinical trial. And this is the example of Thervac. It's a therapeutic hepatitis B vaccine. We all know in chronic hepatitis B, large amounts of viral proteins is made in the liver, and these viral proteins interfere with the immune response. We know even lots of E antigen can be sometimes immunosuppressive because of the vast amount of antigen in the liver. So in this particular Thervac approach, small interfering RNAs are used to suppress the expression of hepatitis B viral proteins. These siRNAs bind to messenger RNAs that make hepatitis B viral proteins, and by doing so, the infected cell receives a signal that viral RNAs are no longer required and starts removing the RNA species. With that, virus protein expression gets knocked down. So you can see here, when you start using siRNAs, the amount of protein expression in the liver of the rodent gets knocked down a little. Then you couple it with subsequent vaccination, which is a prime boost pangenotypic mosaic vaccine delivery approach, wherein two protein-based vaccines are given, subunit vaccines are given, and which is followed by a vectored formulation, an MVA containing hepatitis B vectored vaccine. This is used as the boosting third dose here. And what really happens after turning down the production of virus proteins, when you give this vaccine, if you have turned it down, and when you give the vaccine, the animal is actually able to eliminate the virus, and the person can move towards cure from hepatitis B. As you can see, the number of smileys here. But if without siRNA, you give this this vaccination schedule, you may not be successful enough, and the virus may persist. Here's a classical example of a therapeutic vaccine which is under active trial, and results of it will be known soon. Therapeutic vaccines can be also used in cancer, as I mentioned earlier. So the soluble cancer antigen is delivered to the person, and this is taken up by immune cells. T cell priming and activation happens. T cells migrate to finally the site of the cancer, and there they infiltrate the tumor. There is recognition and killing of the cancer cells. The cells get lysed, and tumor antigen again gets released, which again follows this cycle of being primed by the T cell, and there's activation of a larger number of T cells, which help to kind of attack the cancerous cell by virtue of recognizing its unique antigens. I spoke about the TB vaccine. The vaccine approach to future epidemics and pandemics, it needs to be a sustainable approach, and it has to be a global public health driven approach, not for those who just for the haves, but also for the have-nots. Equitable access to different platform technology should be there. It should be decentralized. There should be localized innovations in countries so that even LMICs can take up manufacture. There should be multiple developers of multiple platforms. And then only whatever vaccination approach we take can reach the last man standing. There is no guarantee in achieving success in the time of a pandemic. So like I said, various platforms have to be taken up. Parallel investment has to happen using various platforms so that you will hit on something that is good. The speed of vaccine development is a game changer. And that we saw, as I mentioned again, in the case of the mRNA and the vector-based vaccines, where they were able to make up the vaccine quickly, and also the nimbleness of the technology that can cope with the emergence of vaccine mutants or variants. If you look at the number of vaccines that have been developed based on disease transmission route, these are vector-borne diseases, these are respiratory transmitted diseases, STIs, food-borne, contact with infectious fluids and direct contact. The real arena where vaccine candidates are surging forward is in the respiratory transmitted disease arena, obviously because we all know a pandemic is most likely to be caused by a respiratory pathogen because of its speed of spread. Successful vaccination in the face of a pandemic requires these very important criteria, and I cannot overemphasize. The vaccine has to be stable. It has to have stability while it's being shipped till the time of administration. The route of administration should be something easy to deliver. Ideally, its wide availability should be there. cost should be attractive so that it is available. There is vaccine equity across the different nations in the world. There are manufacturers and policy makers and those who have issued licenses for a vaccine in a geographic region need to be very stringent with the reporting and the recording of adverse events, whatever they are. And we need to constantly engage the community and public while we're introducing novel vaccines in record time, as we saw with the pandemic, because a lot of misinformation, disinformation can be counterproductive for the use of a new vaccine in event of a dangerous pandemic. And with that, I'll close here. And I could see a number of questions coming to me while I was speaking, but didn't want to get distracted. Thank you for your patient listening. And now we can have, I guess, a time of interaction. I'll stop sharing, or shall I keep the screen?
Thank you, ma'am, for such a nice, comprehensive talk. One of the question is, can you please explain why the approved vaccine of dengue and malaria are not complete success?
One, because as you see in for malaria, the immune response in adults has not been as good as with young children. And you asking about dengue also, right? Isn't it?
Right.
Yeah, dengue. The best, the favored, and the licensed vaccine is Dengvaxia. But the problem with Dengvaxia is it can be given only in regions that are endemic for dengue. If you give it in regions where there's no endemicity for dengue, what happens is you've given the vaccine, and then if that individual experiences natural infection, what it becomes like a dangerous secondary dengue infection, which could be sometimes catastrophic. So it is good for dengue endemic regions, but in parts of the world which are not like Scandinavian countries, countries where are relatively spared of this mosquito-borne illness, it is not very favorable. So America has got dengue because it has parts of the country that has lots of mosquitoes. So it has worked well in America, the United States of America, but not uniformly all over the world.
Yes, ma'am. Another one is that with regards to BCG and bladder cancer immunotherapy,
Yes.
is it also categorized as a therapeutic vaccine?
Yes, yes. BCG is also considered as the introduction of BCG as a immunopotentiating agent in bladder cancer is a therapeutic kind of vaccine approach or immunopotentiating approach. It has been used quite widely, but I'm not very sure whether it had formal clinical trials. Maybe I'm wrong, but the Thervac is undergoing formal clinical trials to see whether we can actually get rid of this virus, which, typically what is said about hepatitis B is if you're infected, you don't really clear the virus. So we will see the results of this, and then I'm sure therapeutic vaccine is a page we need to look out for because it will be the answer to many of not only our chronic infections, but cancers, like you just said, bladder cancer and other cancers to follow.
In case of live attenuated vaccine for HIV, if the patient gets symptoms after 2 weeks, how can we differentiate that it is due to vaccine or due to a fresh infection?
That is little difficult to delineate, but usually due to the vaccine, the symptoms are quite mild. They are not, of course, a person may have a rash, may have a slight, the child may have slight fever. Like if you take the example of measles, there is a huge bit of difference between the mild illness that a child may experience after getting a live attenuated measles vaccine vis-a-vis a natural measles infection. A natural measles infection, the child is much, much more symptomatic.
Ma'am, another topic of interest is adult vaccination. So, is there a universal guideline for adult vaccination and any guideline or protocol for a post-transplant infection or vaccine, either
So
prevention or therapeutic?
So I'm not. I think there are different associations in different countries have vaccination schedules which are tailor made to. Like for instance, we encounter a lot more CMV early in our life. So CMV is something that is not, though it is a problem, particularly in the bone marrow transplant situation, to some extent in the renal transplant situation. The magnitude of the problem in Western countries is quite different. So I'm just giving an example, not that we have a CMV vaccine that's licensed for use in our country, but so vaccination schedules in transplant population, there is a set of vaccines that are prescribed based like for definitely in the Western world, you may want to give a hepatitis A vaccine. They may have already received a hepatitis A vaccine in childhood, but that's a vaccine they will not forget to give. Whereas here, we might say, oh, the person is already exposed. Ideally, we should give a hepatitis A vaccine in somebody we think is immunosuppressed, even in our setting, not thinking that the person is exposed, but priorities may vary. So those post-transplant vaccine schedules may vary regionally. Adult vaccination, again, there is not a set of vaccines that we need to take, but we are going to see a whole slew of adult vaccines for the geriatric group, for the adult group, like, even the HPV vaccine can ideally, though, to be given in pre-adolescent girls, can be given is licensed for use in our country right up to age 25. So there we will see these vaccines being formulated into strict schedules based on the age band. We know in the geriatric age group, definitely influenza vaccine, pneumococcal vaccine, Shingrix, RSV vaccines. These are all going to come. Some of them have not come into our country yet. As far as I know, the RSV vaccine has not yet come, at least not into the smaller towns in India, but it's due to get into our country very soon. But we have influenza, pneumococcal, Shingrix, all this is there already in our country. So we will see those schedules being formulated also, just like we see it for childhood vaccines.
All right. Thank you, ma'am. I think with that, we've taken all the questions. Thank you again a lot, ma'am, for taking out your time. I know how busy you are to take out time
No,
for IAMM. Thank you so much, ma'am.
it is my pleasure and my duty, being a member of the IAMM, to put in my little bit. I do hope the attendees of the Zoom found it useful. I'm happy to take more questions if required.
I think that's, thank you, ma'am. So with
Okay.
that,
Thank you
we,
so much, Dr. Sonal. Thank you for inviting me to give this talk.
thank you, ma'am.